welcome to Medical Dialogues. I am Dr. Nandita Mohan, and today we bring to you yet another exciting episode of the Right Turn Show, where we take the inputs of leading doctors on their practical pearls on the use of Dapagliflozin. Now, in the last episode, we delved into the consideration of Dapagliflozin in specialty care settings. Going ahead in this episode, we will extend our focus to the various fixed dose combinations of Dapagliflozin. So joining us today are two eminent doctors whose contributions to their respective fields have been so impactful that they hardly need an introduction. We have with us Dr. J.C. Mohan, a luminary in the field of cardiology. He currently serves as the chairman of the Institute of Heart and Vascular Diseases at Jaipur Golden Hospital, New Delhi, and is also the consultant emeritus at Fortis Hospital, Shalimar Bagh. Dr. Mohan has an impressive academic legacy with over 370 indexed publications, 3 books, and 87 book chapters to his credit. Also joining us today is a renowned endocrinologist, Professor Abdul Hamid Zargar, who is an MD, DM in endocrinology, a leading expert in diabetes and endocrine care. He is based at the Center for Diabetes and Endocrine Care in Srinagar, Jammu and Kashmir. Professor Zargar is a member of the High-Powered Committee on Health and Medical Education for the Government of India Vision 2035 and a recipient of the prestigious Economic Times Award in 2021. We welcome you to Medical Dialogue, sir. It's an honor to have you both here with us today.
Thank you.
Nandita, pleasure, and thank you for your affectionate introduction.
Great. So I'll start my questions with you, Dr. Hamid. So how would you prioritize between these combinations? That is monotherapy, a dual fixed dose combination, or a triple FDC when managing T2DM patients with different stages of glycemic control needs?
Nandita, when we are talking about type 2 diabetes, it is a disease which is characterized by insulin resistance and insulin deficiency. Insulin resistance reaches a peak, and beyond a point, it does not worsen. But insulin deficiency is a progressive process. This is the crux of progression of type 2 diabetes mellitus. When we give a good control, this progression of loss of beta cells, which we in medical terms call as beta cell apoptosis, can be slowed down but cannot be stopped, because we still cannot control the intrinsic factors that are responsible for this progressive beta cell loss. Now, when we diagnose a person, and if we really diagnose a person in time, monotherapy would suffice for some time. And conventionally, like we have been using for more than a couple of decades, metformin initially. But a time comes when, it would not be good enough to give a good glycemic control. Then we need an additional drug. And ever since gliptins came to the market, they have become quite popular. Prior to that, we used to use quite a lot of sulfonylureas, pioglitazone, alpha glucosidase inhibitors, but now with the major benefits of these gliptins, most of the times we would add a gliptin in the past. But for the last decade and a half, now we have a new class of drug that you alluded to, SGLT2 inhibitors. Now, predominantly metformin, gliptins and SGLT2 inhibitors are used at different stages of the disease, depending on how long the disease has been there, what is at any given time the magnitude of the diabetic control as determined by the hemoglobin A1C, and what are the other collateral characteristics of this patient. Like, I'll give an example. You have a patient who is on metformin. He needs another drug. If he is obese, if he has lipid abnormalities, if he has hypertension, if he's relatively younger, if there is a history of a heart disease in the family, we will add a SGLT2 inhibitor. If a person is thinner, if a person does not have any collateral issues, if a person has a propensity for developing, let's say a lady had a recurrent mycotic infections, urinary infections, we will end up in giving a gliptin. But a stage would come when even whatever dual combination we give, maybe half a decade later, 8 years later, a decade later, a third drug would need to be given. Now, these three drugs have become quite popular in the last decade, ever since SGLT2 inhibitors came to the fore. So, if initially we gave it, one drug on an average would give a reduction of hemoglobin A1C by 0.8 to 1. Gliptins on an average in the Western literature have been shown to give A1C reduction of 0.7, 0.8. But data has shown, established, published data, that in our population, subcontinental population, it can give an A1C reduction of up to 1.4. And gliptin, these SGLT2 inhibitors, are known to give a hemoglobin A1C reduction of 0.8, 0.9. So if somebody's hemoglobin A1C, let's say something like 6.7, 6.8, one drug would suffice. If it is 7.88, we would need two drugs. But if it is more than 9, then probably at that given time, we might start with the triple combination.
Great. Definitely. That's very well categorized, sir. The value-wise indication of when you need to go for monotherapy or a dual FDC or a triple FDC. Now, a similar question for you, Dr. Mohan. From a cardiology perspective, how would you differentiate between using dapagliflozin monotherapy, as sir suggested, the gliptin combination, the dapagliflozin sitagliptin dual FDC, as well as the dapagliflozin sitagliptin metformin triple FDC, and how do you prioritize these therapies for patients with cardiovascular risk, including those with heart failure or even an established ASCVD cases?
So our algorithm is much simpler, and obviously when you talk of monotherapy with dapagliflozin, we have relatively limited indications, and these are individuals with diabetes or without diabetes. Without diabetes, using dapagliflozin, the main indications continue to be heart failure of any phenotype and CKD of any phenotype. With regard to dual therapy and triple therapy, obviously these patients have to be diabetic, and indications now come in the form of atherosclerotic cardiovascular disease, heart failure of any phenotype, and CKD of any phenotype. If I am going to use monotherapy dapagliflozin, the nuances of which have been explained by Dr. Zargar, we apply the same principles, but our algorithm is very simple. In case HbA1c is 1% above the target, monotherapy, 2% above the target, dual therapy, and with 3% more above the target, triple therapy to begin with. However, we'll tweak these as the time goes by and the patient responds, and the response may be very, very variable. Monotherapy with regard to heart failure with any of the phenotypes, reduced, mildly reduced, or preserved ejection fraction, there it remains a class 1A indication. Similarly, CKD of any phenotype, diabetic or non-diabetic, dapagliflozin remains a class 1 indication, barring of course few exceptions like lupus nephritis, polycystic kidney disease, where, and probably to some extent actually other autoimmune nephropathies, although the data is now actually being accumulated in that direction also. But we have also seen that certain other situations where we initially thought dapagliflozin may work, like following myocardial infarction in diabetics or non-diabetics. Unfortunately, the DAPA-MI study, although positive from win ratio, but from hard endpoints like cardiovascular death, first non-fatal MI and first non-fatal stroke, was negative, and hence the role of dapagliflozin as monotherapy in non-diabetic individuals is now confined to CKD and HFrEF, heart failure, sorry. And of course, with regard to dual and triple therapy, of course, the patients have to be diabetic, and there is a much broader range where we use. And I already told you our philosophy of HbA1c being above 1%, above 1%, 1% above target, 2% above target, and 3% above target. We probably you have been using this that's this way of treating diabetes. We also have to tell you that currently in India, the kind of data we have generated, 60% of our heart failure patients have diabetes. We also have, the recent data says, patients at least who have atherosclerotic cardiovascular disease and who actually are candidates for coronary revascularization, 40% of them have atherosclerotic cardiovascular disease. And this number is slowly inching up as decades pass by. And most recent data probably is a little more frightening, but let's look at those numbers as 40% in atherosclerotic cardiovascular disease and 60% in heart failure.
Great. Definitely, the figures are alarming. Now, talking specifically about the FDC of dapagliflozin, sitagliptin, and metformin, Dr. Hamid, what is your take on this combination, and how and when would you apply this combination in your clinical practice?
Dr. Mohan made that answering this question relatively simple. Now, suppose somebody comes, and which is not rare, comes with a hemoglobin A1C of 910 and apparently has not been aware of presence of diabetes, and certainly 300-400 blood sugars and 910. In many situations, we would advise the person insulin initially, but many people are reluctant in our country, particularly initially, because for the first time when they go to a doctor. If HbA1c is more than 3%, what we want it to be, like, you see a young person, 42 years old, hemoglobin A1c of 9.5. I would love him to have a hemoglobin A1c of 6 or 6.5 at max in another 3 to 6 months. If he is obese, a triple combination is ideal for him. There is data available which shows that if in a newly diagnosed diabetic population with type 2 diabetes, hemoglobin A1c of 910, even you can get down an HbA1c by even 4% if you initially give it. So yes, triple combination has a role, and it can give a robust HbA1c reduction. Now, second and the most important thing from our own endocrine point of view is that we have been using triple combinations prior to this in such situations, like as I told you earlier on, a big dose of sulfonylurea, metformin, pioglitazone. But with a bigger dose of sulfonylurea, we are every time scared of hypoglycemias. And if you initially give a huge dose of sulfonylurea, the maximum tolerable dose, sometimes it can be life-changing and life-shaking if a person develops a protracted hypoglycemia. So with these three combinations, we have become bolder. I must tell you, we were rather scared in the initial 2-3 decades of my professional life. You're inching that sulfonylurea milligram by milligram. But here I do not care, giving 100 milligrams of sitagliptin, 1 gram of metformin, and 10 milligrams of dapagliflozin. I feel reasonably secure. And if there aren't any specific issues related to the triple combination, because hypoglycemia. And second, and the most important thing, if the person is obese, our own data has shown over the last 3 decades, we are a part of a global group known as Non-Communicable Diseases Collaboration Group. And this group has been looking at how non-communicable diseases have been doing globally for the last decade and a half. The last paper that we published on obesity showed that from 1975 till 2014, in 1975, we had the 19th position in terms of obese males in the country. But today we have the 5th highest number of obese men in the country. And if men have grown fatter, the women have got worse. Data shows that today we have the 3rd highest number of obese women in the country after China and United States. So these are the drugs that not only are weight neutral, but metformin and SGLT2 inhibitors do cause a reasonable loss of weight. And in a person who is obese at the body mass index of or 27, 28, these 5-6 kilos will make a huge difference. And last but not the least, I would reiterate what Professor Mohan said, cardiovascular benefits, because even at the beginning, when we know a person already has a significant dyslipidemia, seeing a triglyceride of 300, 400, seeing a LDL of 180, 220 is not unusual in our population. Seeing a very low HDL is not unusual in our own population. And 2/3 of people from the very beginning will have some of hypertension. So yes, in those situations, if person is reluctant to use insulin, we use it and we sort of ask them more frequent follow-ups. If in a routine situation we ask a 2-3 months follow-up, such a patient we might ask him to see him again in 4 weeks, then 8 weeks, till we are comfortable with his glycemia and there aren't any issues in this triple combination. But today, we've been using it for a long time and we are pretty comfortable with it at this given juncture.
Well, very well explained, Dr. Hamid. Now, Dr. Mohan, we're talking about this triple, that is the FDC combination, the dapagliflozin, sitagliptin, metformin, FDC. Now, we all know that this comes with robust experience both internationally as well as in India with individual molecules. Now, they are backed by vast scientific evidence of CV benefit and also safety. Now, what is your take on this triple FDC and when would you consider them in your patients?
So, Nandita, the way we currently practice diabetic cardiology or cardiovascular diabetology, nearly 50% of our patients are candidates for this triple drug fixed combination therapy, or they are being used in these 50% of the individuals. We are aware of the individual efficacy of these 3 class of agents and also relative indications. Obviously, as Dr. Hamid said, thin individuals, the people who have recurrent mycotic infections, you would have to think in terms of avoiding dapagliflozin. Obese people, metformin has to be there actually. And the issue which is important, of course, to us with regard to this triple drug combination is we find a lot of advantages. One advantage is lack of hypoglycemia. Number 2, better compliance. Number 3, reduced cost of the triple drug therapy. And above all, patients seem to like this fact that patients don't have to visit the physician that often. Quite often diabetes gets in that range, or the values get in that range where patient feels probably these values are all right, although we may still be asking for a stricter control. Nevertheless, there are positive benefits with this triple drug combination. The only issues, of course, are sitagliptin 50 and 100 milligram. You know that the EGFR is an important issue, and there are in our situation around 15% of the patients whom we see in our day-to-day practice, either because of heart failure or atherosclerotic cardiovascular disease, who have stage 4 of CKD, where you can give dapagliflozin, but metformin would have to be avoided. So there are caveats in our practice, but nevertheless, a good majority, which is about 85% of these patients, the triple drug combination is a good choice, provided the the targets are such whether we want to achieve those targets with HbA1c, we want to reduce in the range of 2.5 to 3% from the current level. As I told you, the benefits are obvious to our patient, but much more important is the cost. Cost has definitely come down with this triple drug combination remarkably. Besides the cardiovascular and renal benefits, the cost also plays an important role. And this has been one of the game changers, or something which has caused a paradigm shift in management of diabetes in our hands. Now we are finding more and more cardiologists treating their patients with diabetes on their own, rather than sending each and every patient to endocrinologist, which was our practice 10 years back.
Yes, yes. Now, Dr. Hamid, coming back to you lastly, to ask you, what is your approach to counseling patients on the added benefits of the dapagliflozin based combinations beyond the glycemic control, such as weight reduction? We're talking about obesity and even blood pressure management.
Extremely important. Now diabetology cannot be practiced solo. You need a setup for it. You need a counselor, you need a dietitian, you need a nurse educator, and that's why Mohans and like him cannot completely take over diabetes, because our systems are more robust on chronic diseases and their systems are more robust on acute complications of chronic diseases, right? Acute events and all that in a lighter vein. Weight loss an important thing, because by the time people get diabetes and you have obesity, many times people have tried things to lose weight unsuccessfully. So I tell them that if you lose few kilos of weight, and this is the drug you need to use, you might have a bit of an issue to get acclimatized to a bit of a additional urination initially. We need to be a little bit careful for the first few weeks to find out that you are tolerating it well. But losing few kilos is quite good. And more importantly, this is visceral fat, which in coarse terms is abdominal fat. We have a unique Indian phenotype where we apparently may not look obese. Like, looking at the shoulders, looking at the limbs, looking at the arms, we may not look obese. But a significant population in the Indian subcontinent have central adiposity. Abdomen is becoming like shelves, suddenly pouting out. So people, it is appealing to people that yes, this relatively obscene projection of abdomen, if to some extent, may not be 20-30 kilos, but 3-4 kilos. So it becomes appealing. And second thing is, we have found many people whose hypertension on triple combinations was not well controlled. And certainly with some of the renal effects of dapagliflozin, it might have a salutary effect on hypertension. You say systolic blood pressure of 5, 6, 8 or 10 may not appear huge, but you have no idea. Ask our cardiology friend how much it means. A reduction in strokes, reduction in cardiac events, and a diastolic of 4 or 5. But most important is, without spending any additional money, cardiovascular protection, all SGLT2 inhibitors, right from phase 2, phase 3 clinical trials to cardiovascular outcome trials, consistently showed reduction in hospitalization for heart failure, whatever the cause of that heart failure, and significant reduction in the progression of chronic kidney disease. You see, in our lifetime, till I became a professor of endocrinology, chronic glomerulonephritis, chronic pyelonephritis were the commonest cause of need for renal replacement therapy in terms of dialysis or kidney transplant. Today, the most important reason for renal replacement therapy is diabetes. And data has shown, DAPA-CKD showed that this process of dialysis can be delayed for more than 4 years if we strategically place this dapagliflozin in the management protocol in time. So in a similar fashion, not only it happens in diabetics, it can happen in many patients who have a non-diabetic kidney disease. IgA nephropathy, forget about others, it has been shown it stops its progression or slows down the progressive drop in the EGFR. So in a similar fashion, we have data not only for the cardiovascular outcome trial of DAPA, but also of DAPA heart failure, which significantly showed 1/3 of reduction in hospitalization for heart failure in patients with propensity for heart failure, whether they had diabetes or not. So when we tell people that, in coarse terms, we tell people it is not only weight friendly, it will do magic with your blood sugars, but you might reduce weight, but it is also good in the long run for your heart. It is good for your kidneys. And many people do comply thereafter. The only problem is many systems, where people do not comply. Nobody spends time with the patient to explain him why we are giving this triple drug combination. In the contemporary world, people want answers. People don't want, it's not olden times the way we used to practice 40 years back. Just write a prescription and it will be taken care of. Today, people want answers. Youngsters would come with a patch from the Google or something, you're giving me 3 drugs. So we need to spend some time with them. Yes, we are very fortunate. We have these triple drug combinations in our country, and as Professor Mohan said, the cost has remarkably come down. So literally everybody can afford it. Literally and imagine now somebody taking 3 tablets in the morning, 3 tablets in the evening. Now you have taking 1 tablet. So compliance is much better. When you take 6 tablets, sometimes a tablet you have missed out, or it's finished. You did not replace your supplies. So, and then adding hypertension medicine, also dual combination, triple. Imagine now 3 of them. Add a tablet for lipid management. So these combinations have made life comfortable for medical professionals as well as for patients. So many benefits there are, and we need to put in a word so that people do stick to the treatment.
Great. So definitely, patient compliance is one important indication, one important factor actually. Now, Dr. Mohan, lastly, given the rising prevalence of chronic kidney diseases in T2DM patients, how does the inclusion of dapagliflozin in combination therapies actually influence your decision making for these high-risk patients?
So as a preamble, I did say that CKD prevalence is increasing, more so in diabetics, as Hamid said. And I already told you that we are seeing a good number of CKD patients, and this is an important indication for initiating dapagliflozin or substituting another anti-diabetic drug with the dapagliflozin. We started the journey with Credence, with canagliflozin with regard to CKD. Then we came with DAPA CKD, and finally we had an EMPA kidney trial, and of course CORED with the sotagliflozin, which of course had to be cut short because of the COVID, but still very impressive data even from CORED trial, which Dr. Deepak Bhatt presented in 2022. We have but let's focus on dapagliflozin and CKD. We did actually see remarkable benefits in diabetic as well as non-diabetic CKD with dapagliflozin. In fact, the benefits were very much similar. Numerically, probably benefits are slightly more in non-diabetics, but statistically, the p-value for interaction was not different whether the patient was diabetics or non-diabetic. What kind of benefit did we see, and why do we want to give dapagliflozin to these individuals? A 39% reduction in all events and 44% reduction in renal events. Remarkable. You could delay, you could avoid renal replacement therapy in 41% of the patients, those given dapagliflozin. That was remarkable. you could actually, all cause mortality could be reduced by 31% in patients with CKD with dapagliflozin. That was remarkable. And that kind of data has not been shown even in heart failure with reduced ejection fraction, or for that matter in atherosclerotic cardiovascular disease, barring of course with EMPA-REG outcome, which probably was the outlier for many reasons, although many people may not agree. But that impressive reduction in all-cause mortality, which we have seen in DAPA-CKD, clearly tells us that the renal patients, CKD patients, are at a much higher risk, and dapagliflozin provides enormous benefit to these individuals. Actually, there has been a meta-analysis published last year, which says that in case you start dapagliflozin in a diabetic patient who is albuminuric, you and at the age of 55 years, you can add life by 4 years. And in case you start at a later age, 65 years, you still can add about 2.8 years to life, which is remarkable. So you are not only preventing renal replacement therapy in these individuals, you are allowing them to live longer with dapagliflozin. And I think this is a very important message which needs to be given through these medical dialogues, that dapagliflozin is an absolutely, on top of course, anti-RAS agents, they also have renoprotective benefits. And now, of course, we also have role of finerenone. And of course, we should not forget the role of statins, and of course the role of GLP-1 analogs are also coming in renoprotection. But the maximum benefit continues to be with SGLT2 inhibitors like dapagliflozin, and a 4 years adding 4 years to life, I think, is remarkable with these SGLT2 inhibitors in CKD.
Great, great. Thank you so much, Dr. Hamid and Dr. Mohan, for joining us today at Medical Dialogues and being a part of this Right Turn show. It was lovely to be gathering all your insights and interviewing you here today. So thank you once again for joining us today at Medical Dialogues.
It was a pleasure.
Thank you,
connecting
Hamid,
with you and Professor Mohan.
Yeah, thank you.
Take care.
Never miss a medical update from Medical Dialogues. Like, subscribe, and press the bell icon.